Good morning, everyone. My name is Yvette Kelly, and I'm with the Managed Care Technical Assistance Center, and I'd like to welcome you to the Managed Care Services Carving In for Children webinar. Today, I'm joined by my colleagues, Boris Vilgorn and Ann Cuppinger, along with some of our state partners. So before we get started, just want to review a few housekeeping things. As always, the slides and recording from today's webinar will be posted and available at our website, mctac.org. Information and timelines are current as of the date of this presentation. And please remember this presentation is not the official document, and you'll need to refer to the provider and billing manuals for official guidance. Lastly, at the end of today's presentation, there'll be an opportunity to ask questions. We are asking participants to please submit your questions via the chat box feature on the right-hand side of your screen. And also, please feel free to submit your questions at any point throughout the presentation. The purpose of today's webinar is to detail some of the upcoming changes related to the transition of behavioral health services to managed care for children. Before walking through some of the changes scheduled to occur next month, I want to take a few minutes to remind everyone of some of the key components of the children's transition. So within the last year, New York State has made available 6 new state plan services for children and their families. 3 of these services begin in January of this year. The next service that will be made available is Family Peer Support Services, which is scheduled for July 1st, with the remaining 2 services becoming available on their implementation date. Another key component was the transition from waiver care coordination to health home care management, along with the transition of the 6 1915C waivers to the Children's Consolidated Waiver, which occurred on April 1st. There are several aspects of the transition that are scheduled to occur in October, pending CMS approval. This includes the alignment of the 1950C HCBS under one array of home and community-based services, and the transition of voluntary foster care agencies to managed care. However, for the purposes of our discussion today, we're going to be focusing on that last bullet, which is the transition of certain carved-out behavioral health services into the managed care benefit on July 1st. Here is the updated timeline that incorporates all of the aspects of the children's transition, some of which I just noted, along with the expected timeline for the remaining transitions that are upcoming. I said it before, but I'll say it again, that this is just a reminder that these future transition dates are subject to CMS approval. All right, so there are a number of existing state plan behavioral health services that have been included in the managed care benefit package for adults, which most of you are probably familiar with, but have traditionally been carved out for children. However, beginning July 1st, that's going to change. So on July 1st, the behavioral health services and managed care for adults 21 and older will be carved in for eligible children and young adults under the age of 21. This includes all of the services you see listed here. And just a reminder, for some of the services, the minimal age to receive the service is 18 and therefore would not be available to those younger than that. Also happening July 1st, behavioral health state plan services are being carved in for children who have federal Social Security insurance disability status or been determined Social Security insurance related by New York State, and children enrolled in OMH specialty clinics who have met the criteria for a serious emotional disturbance or SED. Just a quick note here that I'm sure there will be questions as to whether this applies to dually eligible children, and the answer is no. Just to reiterate, at this time, dually eligible children are not being carved into this transition. So what exactly does all of this mean? It means that beginning July 1st, providers will begin billing for these services following the procedures defined in the New York State Health and Recovery Plan Mainstream Behavioral Health Billing and Coding Manual. It's a mouthful, but I've provided the link here. This also means that providers need to ensure that the necessary authorizations are in place for services provided after July 1st. So providers should begin checking and identifying those being served who are under the age of 21 and contacting their managed care plan to confirm authorizations are in place. Also, to ensure there's a continuity of care, children can continue to see their same providers for up to 24 months for a continuous episode of care, regardless of whether the provider is in that child's plan network. For the services discussed today, however, plans should ensure that authorizations are provided for those existing providers and service levels for up to 60 days post the carve-in date to ensure that there are no gaps in coverage or services until such time that the plan and the provider can get together and develop an established arrangement for the continuation of those services. Please note that this requirement does not prohibit plans from conducting utilization management on these services. And so again, providers and plans should be working together to ensure children and families have continued access to needed services. And with that, I'm going to pass it over to Boris to take us through the remainder of the presentation.
Excellent. Thank you, Yvette. Appreciate it. And good morning, everybody, and happy Friday. So I'll take us through really service and program by program as it relates to the transition on July 1st. But again, we'll keep underscoring the real need for you to start and continue communication with managed care. Also, just to mention, this transition applies to individuals under 21. So as Yvette mentioned, some of the programs that are impacted by this, usually don't refer to themselves or think of themselves as children providers. And so, making sure that you are paying attention because this does apply to you. As well, as long as you're serving anybody under 21, this transition for these programs and services applies to you. Also, it's important to underscore that there are no new individuals or children being enrolled in managed care. All of the individuals we're talking about that being carved in, or the services we're talking about that being carved in, all of these individuals are already in a plan. So again, you can today already identify which plan the individuals you're working with are enrolled in, and thus start working with those managed care companies. So again, wanted to make sure you were aware of that and are not waiting for any additional information. So the next number of slides, we'll talk about the Serve Community Treatment, or most of us call it the ACT program. One of the things that applies not just to ACT, but to all the services, again, in programs we're going to talk about, is there is no change in the process or policy in regards to how they operate, how you get authorization, how you work with managed care organizations, and any other partners that might be involved in working with. We will go through a quick review of the process, but again, just wanted to make sure folks understand that that process is identical and continues to be as you have been working in the past, I suspect, 3 years, especially for the adult programs or programs like PROS Act and a number of OASAS programs. What we're really talking today about is a billing change on July 1st from fee-for-service Medicaid to managed care for those individuals who are enrolled in managed care, and that's kind of the big piece of the information. So with that being said, and I'll remind folks again, when we talk about referrals to ACT, they're the same as you have been experiencing before. You do need the level of service determination, both in New York City and the rest of state. But we would suggest you, kind of work with and look at the utilization management guidance. If you're not familiar, I suspect you probably are. The referring provider must contact the managed care organization. The managed care will review, the level of service and make a determination within 24 hours in regards to the act. Again, this is continues to be the process for under 21, as you have been applying and working with for 21 and over. Authorization, continues where you will work with a managed care organization as an ACT team to obtain that authorization, both prior and as a concurrent review, making sure that, you have the right pieces in place. And again, require that the concurrent reviews for the assessment of services plan dates are 6 months and so forth. So this is a brief review. So some of these slides and information I'll probably go through pretty quickly because I'm really hoping and believe that if you're an ACT provider, you should be very familiar with this, and it doesn't change. Same thing with billing. The billing remains the same. You'll be continue to using the last day of the month in which the services were rendered. So, for example, for the July transition for individuals under 21, for July, you would be using July 31st as your billing date. So there should be no real issues in the billing transition to managed care for those individuals. And as always, ACT services authorizations are in units, and you have 3 rate codes that talks about full payment, partial, and hospital. With the billing overview, kind of continues. You have the full rate and the partial rate, and as always, you have to reach a certain number of visits per month, and other types of requirements to determine if it's a full rate or partial rate. You also are allowed, as before, to bill and provide services to individuals in inpatient. And again, there are rules in regards to the thresholds for billing, meaning how many you need to do minimum, and also what would constitute a full payment rate for that month while the individual is in ACT and then inpatient. The overview model, just also continues because you can also have be in the clinic and ACT. Predominantly, you use that as a transition point, but, that continues for the individuals under 21 as well with ACT and PROS. And again, the process that you're used to and have been put in place will continue for the individuals under 21. So the transition to managed care for ACT, this is where we do want to spend a little time, is again, it's 18 to 20, as Yvette mentioned. Not all programs, are licensed or served individuals that are under 18. ACT is one of those. So for individuals that ACT serves that are 18 to 20, as of July 1st, you will be billing to Medicaid managed care as long as that individual is enrolled in Medicaid managed care. And again, strongly recommend, and you should really be talking to managed care to obtain authorization prior to July 1st. And communication is crucial in all of these areas, and having those discussions with managed care. And also to make sure that, when you do start billing managed care at the end of the month for ACT, you have all the pieces that are necessary in place, and then managed care is aware on who you're serving and has their system set up appropriately as well. Now let's move towards PROS, or Personalized Recovery Oriented Services program. Again, a referral to PROS, as always, could be made by a practitioner, managed care. It could also be a self-referral. PROS has 3 components, or 3 phases, I should say: pre-admission, admission, and an active rehabilitation phase. The pre-admission begins with the initial visit and ends when an initial service recommendation is sent to the managed care for prior authorization. Admission begins when the ISR is approved, and then the process 90 days to develop an IRP. or individualized recovery plan. And of course, then the active rehabilitation begin when the individualized recovery plan is approved by managed care. So again, just like with ACT, strongly recommend PROS start working with the managed care companies for individuals under 21, starting to think about authorization, the process, and making sure that managed care has everything in place as needed. The utilization management for PROS continues to be the same. When we talk about IR or ORS, it happens at 3 months intervals. For the CRS and clinic, you can do it on a 6 months interval. Again, same process as has been established before. And continued state, just with a lot of services and programs, the member must have an active recovery call that shows progress, and the member requires a PROS level of care in order to maintain psychiatric stability. And also, of course, without PROS services, the individual will require a higher level of care, which is, what you should be used to in the PROS programs now in regards to continuity of stay. Billing for PROS, similar to ACT, again, utilizes the last day of the month in which services were rendered. So just like in ACT, July 1st is the transition date. So for the month of July, you would use July 31st as the date for that billing. So again, should not have any issues in regards to this transition. There's a base rate tier, and PROS, again, PROS providers are very familiar with this in the tier system of billing that has base rates that goes into different tiers. That is a combination of units, or it's units combination of hours and services. And also there's also additional add-on components that PROS programs can utilize for billing. Again, continues with the same protocol and process. Another program that is going in, transitioning to managed care for folks under 21 who are enrolled in Medicaid managed care, is Continuing Day Treatment Program, or CDT. Again, no change in CDT services. They are billed daily compared to ACT and PROS. As always, there's a 3-rate tier. That all depends on hours, 1 to 40, 41 to 64, 65 plus. Then there's a full day or a half day, a minimum, and it continues to be the way you have worked with others. Again, the difference here is your July 1st bill, if the individual is enrolled in Medicaid managed care, would go to Medicaid managed care versus going directly to a fee-for-service Medicaid. So here the transition is really of the date of service, and that is July 1st for this transition. The billing for CDT, the claims you can have for collateral, groups, pre-admission, the reimbursement is equivalent to the half-day tier when we talk about these types of visits. Collateral, groups, pre-admission, and crisis visits are excluded from the calculation of the cumulative total hours in the program for a recipient. Again, just wanted to repeat that there should not be a change for individuals who currently operate CDT programs. Next program we want to talk about is partial hospitalization. That's also has the transition. Partial hospitalization, like CDT, is also submitted daily. So again, for the billing perspective, you will be starting your bills for the date of service on July 1st. The applicable rate codes, procedure codes, and modifiers, they all depend on the number of hours per day, and the regular rate, crisis rate for these services continues to be the same for individuals under 21 as for those who are 21 and over. Continuing with the billing for partial hospitalization, collateral, the clinical support services for at least 30 minutes in duration, but should not be more than 2 hours. Group collateral clinic also supports services for at least 60 minutes in duration, but also not more than 2 hours per recipient and or his collateral. And it cannot include more than 12 collaterals in a face-to-face interaction with therapy. Again, this is a group collateral. And the pre-admission visits are 1 to 3 hours. Continuing with pre-admission, you have, as I mentioned, 1 to 3 hours billable using crisis visit rate codes or 4+ billed using regular rate codes. UA modifier required on all partial hospitalization pre-admission claims, as I'm pretty sure you're familiar with. Both partial hospitalization and CDT, continuing day treatment, require prior authorization and concurrent reviews. So once again, please make sure you're starting those discussions with managed care in regards to obtaining those prior authorization prior to July 1st. OMH clinics has a little bit more in regards to this transition, but definitely are impacted. In OMH clinics, clearly they serve all ages, under 18 as well. So this is, again, applies to all clinics who serve individuals under 21. So in some instances, it might be what traditionally was referred to adult clinics, but definitely children clinics. And so the change for the OMH clinics, as Yvette already mentioned, children who do have SSI and or SAD diagnosis are carved in as of July 1st. So SSI and SAD is no longer a carve-out for children or individuals under 21, I should say, who are enrolled in Medicaid managed care. So please make sure that for dates of services on July 1st and going forward for those individuals, you're billing to the appropriate Medicaid managed care company. And of course, you will continue utilizing the APG rate methodology, which includes the rate code, procedure codes, and all the modifiers to come in with the clinic. So as of July 1st, plans will cover OMH clinics, again, for SED. SED will no longer be able to bill fee-for-service, so make sure that you're talking to your EHRs, billing systems, and so forth to change those processes, whatever processes you have in place. And as I've mentioned before, you will continue utilizing the APG methodology. And what we want to also remind folks, the 30-visit mental health clinic authorization piece is in place for this transition. And what that means is, again, just like with all other individuals being served in a clinic, you do not need to obtain authorization for the first 30 visits in the OMH clinic. However, we would still strongly recommend you have those discussions with managed care. It's always a good idea to notify them of who you're serving. So when they have a record, you can also, from quality and clinical side, have a conversation about the folks you're serving and are going into managed care. Again, so those conversations still should be happening, even though for July 1st you might not require authorization until you hit your 31st visit. And again, multiple services received on the same day count as a single visit, and there's no change to that. So just wanted to remind folks about that. Okay, so the other piece is OMH does have a threshold. The OMH clinics, I should say, have a threshold that calculates, countable service days. And when a certain number of those service days are reached, there is a payment reduction for those services after the threshold. And here's a description of when that happens, and if it's for 21 and older, or under 21, depending on their birth date. I'm not going to go into great detail here, because again, this is not a change from any previous policy that the state have put out there, but I think it's important to remember that there are utilization thresholds. They do differ for 21 over and under, and just making sure everybody understands that. Now what we'd like to do is, so that covers us through the OMH services that are transitioning on July 1st, together with the population we talked about. We also want to cover OASAS services, because it does also impact OASAS programs, and there's a similar process and transition in the sense that all the processes and protocols continue. It's more about the population and who you're going to be billing starting on July 1st, just like with the OMH services. So some of it will be a quick review for folks and a reminder, just like we did with OMH. And there are some, again, reviewing which populations are being carved in on July 1st. So prior authorization and concurrent reviews will continue with the same standards of locator, prior authorization, concurrent reviews, and so forth that you've been used for 21 and over for under 21 beginning on July 1st. So as I mentioned, no change in the process. And we'll start with going program by program, service by service, as we did with OMH through the OASAS system. So Part 818, chemical dependence inpatient rehab, has been really covered even prior to 10.1.15 for all ages and non-SSI. The SSI population was added on 10.1, so this should really not be a transition for this particular program at this time. We also have just a reminder that 820 residential services, stabilization and rehabilitation, and the freestanding Part 820 1115 demonstration services, again, has been carved in during the adult transition, and some of the first providers were certified in August of 2016. So those programs and services have been in place with managed care for a number of years now. As we continue through the OASAS system, moving into Part 822, chemical dependency outpatient services. Again, that includes outpatient clinic, outpatient rehab, and opioid treatment program, including hospital-based Part 82. Again, state plan services were added for adults over 21 as part of the adult transition at that time, and the freestanding Part 822 1115 demonstration services were added for all ages, SSI and non-SSI, as part of the adult transition. So all of these programs, have been really covering and working with managed care for a number of years now. Now, the OASAS services that are transitioning to managed care on 7/1 of this year are Part 18, the chemical dependency inpatient, and that will really include Article 28 and 32 for under 21 and SSI. As we mentioned before, SSI for under 21 is no longer a carve out. So if the individual has been carved out as of July 1st, that will no longer be the case, both for OMH and OASAS. This is one of the programs where this definitely will go in effect. For the chemical dependency outpatient clinic, rehab, and OTP program, for the outpatient clinic, it would be under 21, both SSI and non-SSI that are being carved in. Again, all of the individuals who are being carved in have to be enrolled in Medicaid managed care for that to happen. It would also include outpatient rehab and OTPs, so both outpatient clinic, outpatient rehab, and OTP programs for under 21 for SSI and non-SSI are being carved into Medicaid managed care, as well as programs that are not transitioning to managed care, and those are Part 817 residential rehab services for youth and Part 20 residential services, the component of reintegration. Just to be very clear, because 820 has 3 different components, and here we're just talking about reintegration, as the other 2 have been in managed care. And again, so just underscoring, there are these 2 particular areas that are not being transitioned at this time into Medicaid managed care. So just underscoring, if we haven't said enough, in regards to SSI, so hopefully folks understand that SSI for under the age 21 will no longer be carved out, and it will be included as part of the Medicaid managed care package. And so that concludes kind of the overview of all the service by service and which ones impacted and how they're impacted by this transition. Also want to remind folks Again, this is not a change in any way from the current process with adults being for 21 and over, being in Medicaid managed care regarding the claim submission. Medicaid managed care plans and providers must adhere to all the rules and coding manuals. As Yvette mentioned early on, this presentation is not an official document, and we so strongly recommend you always refer to the billing and coding manuals and other manuals that the state has provided. Medicaid managed care must support both paper and electronic submission of claims. As always, it must offer its providers an electronic payment option, including a web-based claim submission system. So that just continues as before. All claims will continue to be submitted on either 837I, which is institutional claim form, or UB04. Will continue to be utilized for submitting paper claims, and every electronic claim will require, a Medicaid fee-for-service rate code, CPT or HCBS code, procedure modifiers, and units of billing. And you can always refer back to the MCTAC billing tool. We have a link here, so when those slides become available, you'll be able to click on this link, but I suspect most of you are already very familiar with this billing tool. So again, just wanted to remind folks it's there, and please make sure to utilize it. And as always, the insurance law of New York State requires insurers and health maintenance organizations to pay claims within 45 days that they receive claim, or within 30 days if the claim is transmitted electronically. So that continues to be still the policy and actually the law here. And providers are expected to do some claim testing. So even though it is, for a lot of you, maybe not a big transition, since hopefully you've been experienced in working with managed care and you're just adding different individuals to the billing, but I think this might give you yet another opportunity to do some claim testing. I'm always of a mind that, it's never too late and always good to sometimes do some testing to see if everything is in place. And I think this transition might give that opportunity as well. So would recommend that you take advantage of that as well. In addition to the information, there's also, we have some resources that we wanted to provide. There's a link here that will be available for you, again, when you get the slides, to the Utilization Management Guidelines for State Plan Services. And what this really does is, as I've gone through some of the programs in regards to authorization and utilization management, what this document really provides is kind of a more detailed and, program by program, service by service, again, breakdown on prior authorization when they're required, concurrent authorization when they're required or not required, and other additional guidance that it has. So this is really a helpful document, especially both as a refresher, but also, just to have handy. So you'll have the link to this document as we move forward. What we also have here, and I'm not going to go through these charts in details because there's no change, allowable billing combination reminder. So again, certain programs and services are allowed to be billed in combination. There are some that are not. It's predominantly, if not mostly, due to they provide a similar or same service. So wanting to make sure that folks are not getting duplicated services, from different programs. So that's one of the major reasons why you might see sometimes a no versus a yes. But if you can see, there's really a lot where different programs can really work together in providing services, and this just again continues. This touches on other areas, but gives you that breakdown in those combinations. So we have a number of these slides, and I think with that, I know we have received a number of questions. So we're going to pause and look at some of those questions. But before we get to the Q&A portion of this presentation, as we look at the questions, I just want to ask our state partners if they have any additional thoughts or comments that they would like to share with our participants before we turn to the Q&A.
Thank you so much, Boris and Yvette. This is Alyssa Altuel with OMH. I did just want to take a moment to just remind folks that, and I know that we covered this in the beginning, but based on some of the questions that we're receiving, to remind folks that today's webinar has nothing to do with the Children and Family Treatment and Support Services, and so we would just encourage you all to use your regular channels for questions that you have on those services. So nothing that we're saying today applies to those services. And then I wanted to also just reiterate the point that you had made, Boris, around ensuring authorizations for these services are in place by 7/1, and just remind folks that these services that were covered in today's webinar, they're already in managed care for some populations. So any of the prohibitions that may exist for other services in the children's transition do not apply to these services. So plans are permitted to conduct as of 7/1. But with that said, you know, we've been in conversation with the plans, and we're now talking to providers about the fact that you know, plans and providers should work together collaboratively. We don't anticipate that plans are going to be cutting off services for these services that are coming in, and plans do have to kind of honor a up to 60-day transition period to just make sure that everything is set up for these services, but that doesn't mean that providers should wait 60 days to contact plans. Providers should be starting to talk to plans now for the individuals that they're serving that are under 21, and they should aim to have authorizations in place prior to 7/1 so that they don't have to worry about any disruptions in payment or authorization after 7/1. But we do encourage the plans based on standard policy to make sure that if for whatever reason an authorization or a conversation between the provider and the plan couldn't occur prior to 7/1, that, you know, services wouldn't be abruptly cut off, and that there's time for those discussions to take place over those 60 days. So that doesn't mean, though, that plans can't be making determinations about whether the services are medically necessary and whether they should be continued. So I do want to just note that these services covered today are different than the rest of the services that we've been kind of informing providers about, and the continuity of care requirements with that. But we do have the continuity of care requirement for the provider in place for these services. So the child can still see their same provider, or I should say the child or the young adult can see their same provider for up to 24 months for the current episode of care that the individual is in when the services come into managed care. So I just want to address that, and then I will turn it back over to McTack for some questions.
Great. Thank you, Alyssa. Actually, as it regards to the utilization management, we just have a clarifying question, and I think you just spoke to it, but just wanted to put that out there. So regarding the my understanding was there could be no for 180 days, depending on the member. Is that accurate, or is required 60 days after? I know you kind of just mentioned that, but my understanding, again, there is no 180-day not requirement, or I know that's not good English, but anyway.
Yeah, so the 180 days does not apply to the services covered today. That applies to the individual's plan of care for HCBS and CFTSS for the remainder of the transition. So this is very specific to these services, and that 180 days does not apply here.
Great, thank you. And just also wanted to highlight that when both Yvette mentioned and Alyssa talked about the continuity of care in 24 months, again, utilization management does apply. Authorizations are required when appropriate, and and are stipulated. So just because there's a 24 months continuity of care piece here, it doesn't mean that no authorization. You would still continue working with managed care. So just kind of sometimes folks put those two together, but not, they're not necessarily the same. There's another question, I think this is for you, Alyssa. The 5% enhancement for children under 19 will still apply for OMH clinic, Article 31, under Medicaid managed care. Is that correct? Specifically, rate code 1504.
Yes, so the government rates for clinic services definitely still apply here, and that includes the 5% enhancement for children under 19.
Great. Yeah, and I think that just underscores again that, the policies and protocols are still the same. We're just really changing in regards to who's paying, but also changing the work with, working with managed care. So that is very much in line with the approach. There is a question about SCD and SSI Medicaid carve-out. As was mentioned, it will no longer apply to Article 31 clinics as of July 1st. So there was a question about does SCD and SSI Medicaid carve-out apply? So as of July 1st, it will no longer apply. And that is a change for the Article 31 clinics. This one, just to confirm, might be for Maria. And in regards to OASAS Part 817 RRSY, just wanted to confirm will remain carved out. Is that correct?
Yes, the RRSYs remain carved out. And if I might, there was a question about 822 community-based outpatient services.
Yep.
That service will be coming into managed care for all individuals. So the under 21 population will be carved into that service at July 1st.
Excellent. Thank you. A question about CCBHCs. And just folks wanted to make sure that this applies to the clinics that are part of CCBHCs as well, what we talked today about.
So CCBHCs it's my understanding that they are not carving in as part of this transition, but we will take that back and confirm.
Okay. Thank you. I see another question around SCD and value codes. Again, just wanted to underscore, as of July 1st, there is no SCD carve-out. So if you were using any codes like 1510 or other types, there are a number of particular codes that identifies and carves the child out as SCD. It will no longer be applicable, and you need to work with Medicaid managed care as long as that individual is enrolled in Medicaid managed care. So just wanted to again emphasize that because we got a different twist on the same question. This is less about the transition, but again, just I guess a question about 30 visits max. This is for, I suspect, the mental health clinics. Does the 30 visits max authorization include groups within that 30 visits? I don't know off the top of my head. I don't know if, Alyssa, you know if the groups are part of it or not, the 30 visits.
I believe that it's just 30 visits, group or individual, but I would refer folks to the existing guidance that you guys linked on a few slides prior, and nothing is changing with regard to the 30 visits for clinics. So if folks are already used to working within those rules, everything is the same.
Got it. Thank you. I just looking at some of the additional questions that just came in, and please, if there's other questions, please feel free to chat them in. There's again a request to clarify OMH clinics and children under 21. So again, the OMH clinics and children under 21 will be carved into managed care as of July 1st. However, since the OMH clinics do have a policy in place that the first 30 visits do not require authorization, you, and Alyssa, correct me if I'm wrong, but you technically do not need authorization. However, I think notification and communication with managed care prior to July would be strongly recommended, and always helpful in many different ways to make sure you're talking to managed care about both quality, services, and making sure they're aware that you're serving this individual. So this way, if there's any potential for duplication of services or that billing combinations grids that we showed, if there's any issues with that, it would come up during those conversations. Otherwise, you might not be aware that is even happening. So there's many good reasons outside of just obtaining authorizations why you want to connect with managed care prior to July 1st. But from the authorization perspective, the 30 visits do still remain in effect.
Yeah, and I think the best way to say this, and we're getting a lot of questions that are kind of asking the same thing, the best way to say it is that for OMH Article 31 clinic, if the individual is enrolled in managed care as of 7/1, you will be billing the managed care plan. And for the providers who were billing the SED carve-out to fee-for-service, those providers will be billing Medicaid managed care using the standard APG methodology. And so we would encourage you to reference the billing manual that was in these slides, and these slides will be shared. I just want to also remind folks that there were memos that went out with a little bit of additional information on this to providers, and we can certainly link to those maybe when we post these slides, McTack?
Yeah, definitely. We can definitely do that. I think that makes sense. Again, a couple of questions on 822 outpatient clinic, just again confirming that 822 currently bill APG rates, will continue to do for adolescents as they have done with adults. I assume the answer is correct. That doesn't change on the billing protocol. That will continue as is. Just wanted to make sure I'm accurate with that, Maria.
That is correct. You know, the service, the 822 service will be billed as it is with the current practice.
Great.
It's just the population coming into managed care.
Perfect. And another question around 822, it says we currently do not require authorization. Will that change with the carve-in? I suspect if that's not a requirement, there'll be no change, but just wanted to, again, confirm.
That is correct. Anything that you currently do for your 822 service remains the same regardless of the population. We're just bringing the age group into managed care.
Perfect. Thank you. All right, I see one more question here. I'm going to read this one. What about patients already active in partial hospital programs prior to 7/1 and who will remain in partial post 7/1 start? Will they continue to remain as a carve-out, or will they have to start calling managed care companies in the middle of treatment starting 7/1 to get authorization? I'll put my 2 cents in. I suspect they would have to obtain authorization as of before 7/1, but for 7/1 services, and discuss that with managed care. Again, for individuals under 21 who are in Medicaid managed care. Alyssa,
yes.
That's accurate?
Yes, Boris, that is accurate. And I do just want to say that the managed care plans, are not expressing any desire to cut off treatment for individuals that whose services are coming into managed care. So they would need to contact the managed care plan, but we encourage those collaborative relationships between the providers and the plans, and we don't expect there to be any disruptions in care for a current episode of care.
Perfect, thank you. So let me just again remind folks, if you have any additional questions, please feel free to chat them in. At the moment, I don't see any questions that we have not addressed. I don't know, Yvette, Anne, I don't know if we'll give folks maybe another minute or so to chat in if there's any additional questions. think there was a question about where can I find more information about the Article 31 STD carve-in. I think Alyssa mentioned that there is a memo that has gone out that talks about in more detail the Article 31 carve-in, and so again, we'll make that available when the slides are and so forth. So there is more information on that for anybody who might be looking specifically for that area. All right, so I think with that, since we don't have any more questions that are coming in, I want to say thank you to our state partners and Yvette for a great presentation. Again, we'll make sure the slides and the recording becomes available together with the resources we discussed. Hopefully you found this to be helpful. Please, again, make sure you, if you haven't done so, start the conversation with managed care. Make sure you check on who's in Medicaid managed care for this age group, as even though it seems like it might be a little bit less than a month away, but July 1st will be here sooner than we all think. So thank you, everybody, for joining us. Have a great rest of the day and a wonderful weekend. Thank you, everybody.
Thank you.
Thank you.